All right. Good morning, everyone. Please do make your way to your seats. Oh, I love it. Thank you all for that bright attention this morning. Good morning and welcome to the 4th Annual Texas Public Health Summit. Thank you so much for joining us today, whether you're here in the room with us or online. My name is Leah Gobriel. I am the Assistant Director of Marketing and Communications with the Texas Epidemic Public Health Institute, or TEPHI, as we like to shorten it. And I have the honor of serving as your MC for today's event. For those of us gathered in person, we're going to kick things off with a little bit of fun and also encourage any stragglers to make it to their seats. To help us stay on time, after breaks today, we will be raffling off some door prizes. So you may have noticed in the back of your name badge, there is a raffle ticket in there. Why don't you go ahead and pull that out? We're going to do a quick little drawing again to encourage folks to get to their seats if they haven't already. You must be present in the room to win throughout the day. So that's your encouragement. I will read the last 4 numbers. If they're not here, we'll draw again real quick. So the last 4 numbers are 2493. 2493. Do we have a taker? No, going once, going twice. Okay, we'll do one more. Hopefully one more. All right, last 4 are 2572. 2572. No, oh my goodness. We've got late comers today. 2501. Oh, wonderful, wonderful. No? Oh, well, I love the honesty there. That's fabulous. You know what? I feel like that is deserving in and of itself. So kudos to you. And I'll say our door, and I will pass this over here. Our door prizes, she's over to the side of the room. Our door prizes today, we have a custom designed Lotteria sets as well as some travel mugs. So thank you so much for your honesty, and you got to have those tickets handy to win. All right. Now that I have your attention and a little bit of laughter, a few quick housekeeping items to today's summit. Oh, and I forgot to click that. You know what? It doesn't want to click. We'll ask our AV folks to help out. There we go. That's me. That's great. All right, our housekeeping items for today. Today's summit is being recorded and will be available on our TEPHI website as well as our TEPHI YouTube page, probably a couple of weeks after today's event. As we said, we also have photographers capturing today's event. You've probably seen them running around the room. If you received your email yesterday, we put a little note in there. If you have any concerns about the photography, please just visit our check-in table. You should, for those of us joining online, you'll also be able to participate in the conversation today by submitting questions in the Q&A window. I believe the chat has been disabled, but if that is still there, please direct all questions to Q&A. It helps us keep things nice and tidy together. For those here in the room, we will have microphone runners, a couple in blue TEPHI shirts that you can just raise your hand during the panel discussions to ask whatever questions you might have. For, again, those of us in the room, restrooms, very important, are out the doors to my left, so away from the escalators. Coffee will be served all day, just where you got it this morning, outside the doors. And lunch will also be served out in the foyer. It's kind of a build your own lunch today, and you can bring it back into this room to eat and converse. One more note before we get started. We are offering continuing education credits today. Thank you to the Department of State Health Services for that accreditation. So to earn that, you will need to complete the event survey at the close of today's event. We'll have the QR code to share with you at the end of the day to access that survey. We'll also be distributing little slips at the close of the day so that you don't miss out on anything. These are some required disclosures. So again, to earn those CE credits, you have to pretty much remain here all day, with us and complete the participant evaluation. A few notes on those that we'll scroll through quickly for you all. And just a disclosure that there's no commercial support received and no conflict of interest. All right. And with that, I have the honor of presenting our first speaker today, Dr. Janelle Rios. Dr. Janelle Rios is a faculty associate at the University of Texas Health Science Center at Houston School of Public Health, and she serves as our deputy director at TEPHI, which is an innovative institute established by the Texas legislature in 2021. She also leads the Prevention, Preparedness, and Response Consortium, a large multi-site training program funded by the National Institute for Environmental Health Sciences. Through this effort, Dr. Rios and her team equip workers across the country with the skills they need to prevent, prepare for, and respond to public health threats. Her research portfolio extends even further. She was the principal investigator of the Jet Fit study, a 3-year project funded by the CDC, which explored how reusable elastomeric respirators could serve as a practical alternative to disposable N95s in healthcare settings. In addition, she's the consortium PI for the Deployment Safety Academy for Field Experiences, or DSAFE, a training program funded by the U.S. Public Health Service to ensure field teams are safe, prepared, and effective in their deployments. Please join me in welcoming Dr. Rios.
Thank you for that very kind introduction, Leah. It was longer than I expected. Welcome to the 4th Annual Texas Public Health Summit. Today is the culmination of 10 months of planning and a tremendous amount of work accomplished by a wonderful team of dedicated people. Everyone here volunteering on behalf of TEPHI and everybody on the planning committee, please stand up so we can appreciate you with a round of applause. Excellent. Thank you all very much for your hard work. And very quickly, I'd like to share a tiny bit of our history. As Leah mentioned, TEPHI was established in 2021 by the 87th Texas Legislature, and we accomplished our legislative mandate via 4 program pillars. Oh, shoot, I forgot. There we go. So our first pillar is the award-winning state-of-the-art early detection program. Please visit the TexWeb booth outside in the lobby to learn more information about wastewater science and to check out our new dashboard. Next is our training program. Our training team creates live workshops, tabletop exercises, and several self-paced modules that serve as entry and intermediate level courses for Texans that are interested in infectious diseases. The third pillar is the Public Health Reserve Network, and this refers to the group of people that we train and with whom we communicate. Finally, we have communications led by Leah. The communications team actively and elegantly translates complex concepts into straightforward and practical lessons and information. This team has won several awards, some of them at the national level. Our goal here today at the summit is to look forward into the future to consider, debate, and document the needs we will have over the next 25 years. This theme was inspired by Dr. Carlos Plasencia. You'll hear more about him later today. We will also acknowledge past public health accomplishments and learn about the present status of infectious diseases in Texas. First, let's look towards the future. Everyone, please take out your cell phones and open your camera app and go to the QR code shown on the slide here. On your phone, a question will appear. Okay. Is it not working? Oh, it went back? Oh, Dana, help. There we go. Excellent. Thank you. Because we've organized today's summit into 3 areas, transmission, technology, and trust, we wanted to know how you might rank these areas by level of importance as it relates to infectious diseases in our state. On your phone, you may move the button so that you can rank the most important one at the top. And I love this immediate response system. So it looks like trust is winning out. Okay. I'm going to move on to the second question because that was fun. So, okay, Dana, you may have to because it's not working. We'll go on to the next question, and you'll have to open your camera app again and navigate to the QR code shown on the screen, and it'll show in just a moment. And in this question, we're asking you to consider the next 12 months only. So think about the next year ahead. And what will appear is a list. Please choose the 2 that you feel represents the most urgent need to get and keep Texas outbreak ready. So it looks like data sharing is winning. Okay, one more time. One more time. Click on the QR code at the next question while thinking about the next 25 years. So we're thinking long-term here. What long-term investment matters most to keep Texas outbreak ready? And again, you can choose 2. I'll leave it on the screen for a few minutes and let you know that what we're doing is figuring out which areas are most important to you so that we at the university are able to address those areas and work on those. So, okay, well, hopefully it worked. We'll move on to the next slide. And I'm going to say, thank you for letting me tap into your collective wisdom. I'll communicate these results back to you in a report that's going to be ready by year's end. So finally, as I close my opening remarks, I'm excited to learn from each other, to exchange ideas, and to make the most of our day together. I hope you enjoyed today as much as I do. Thank you so much.
Thank you so much, Dr. Rios, for that warm welcome, as well as a little bit of fun interaction there throughout our day. So I have the pleasure now to introduce our first keynote speaker, Dr. Diana Martinez. Dr. Martinez is the Deputy State Epidemiologist and a Senior Epidemiology Subject Matter Expert at the Texas Department of State Health Services. Martinez's career in public health spans more than 35 years. She received a Bachelor of Science in Chemistry from the University of Puerto Rico, Rio Piedras, and a Master of Public Health from the University of Texas at San Antonio School of Public Health. She later earned her doctorate in epidemiology with minors in biostatistics and health services research from the UTHealth Houston School of Public Health. In her current role, Martinez has direct oversight of the disease surveillance and epidemiology section of the Office of the Chief State Epidemiologist. She leads data analysis projects to address relevant public health questions using a cross-cutting approach, with the goal of informing policy and leading to actionable public health activities. Previously, Martinez served as a senior health policy advisor in the New York City Mayor's office and as City Hall's senior liaison to the New York City Department of Health and Mental Hygiene in the Office of the Chief Medical Examiner during the emergence of COVID-19. Before this role, Martinez served as Epidemiology Program Manager and was the lead epidemiologist for Harris County Public Health. During her 25-year tenure in Harris County, she held a leadership role in major outbreaks and investigations. She is an adjunct professor for the UTHealth Houston School of Public Health and the University of Houston Clear Lake. Please join me in welcoming Dr. Martinez to the stage.
Thank you. Good morning. Good morning. Good morning. Let me quickly get rid of that picture. And I'm so happy to be here. Houston is home, and I see so many friendly faces. It's amazing to be here this morning. So thank you for that introduction. And I am elated to see all these faces in front of me. So let's just get started. As stated by the Institute of Medicine in its 1988 report, The Future of Public Health, now you can see it, public health is what we, as a society, do collectively to assure the conditions in which people can be healthy. When I think about public health milestones, my mind immediately goes to an MMWR published about a decade after that quote, which highlights the 10 great public health achievements of the 20th century. This publication presents different efforts that have impacted how long and how well we live. And for the most part, we don't even question these transformations, like the availability of clean water and improved sanitation. It's not clicking. It's not clicking. There it goes. The availability of clean water and improved sanitation. We open a faucet and expect safe drinking water. We use the restroom and do not think about spreading infectious diseases through sewage. The fortification of foods provide us with vitamins and minerals that we need to be healthy. The fluorination of water, its relationship to oral health, improvement in prenatal care, and there we go. Improvement in prenatal care and access to family planning services, which have resulted in healthier mothers and babies. Now you can see, oh, the clicker is not clicking. Am I supposed to do something about this clicker? All right, there you go. All right. So we were talking about healthy mothers and babies. Now the clicker is clicking. All right. All right. Now, enhanced seatbelt use, safer vehicles, designs, road designs, which have impacted the outcomes of car crashes, safe workplaces, the recognitions of risk factors and modifications of behaviors like smoking, which have improved the outcomes of heart disease and stroke, the development of vaccines, treatments, and other mitigation strategies responsible for the significant reductions in illness, hospitalizations, and deaths associated with infectious diseases. Also comes to mind its companion publication. This was published in 2011, and it focused on the first 10 years of the 21st century. This one emphasized evidence-based. I'm gonna have to give up on the slides. There we go. Evidence-based measurable outcomes for these achievements. Once the leading cause of bacterial meningitis among children younger than 5 years of age, Haemophilus influenza Hib caused serious illness in about 20,000 children in the US every year. And about 1,000 of these children would die every year. Today, fewer than 50 cases of Hib disease occur each year in the US, and most of these are in children who did not receive any or all of the recommended Hib shots. A similar story is that of measles. After a sharp decrease in reported cases in the 1960s, following the reduction of the following the introduction of the measles vaccine and further recommendation of two-dose series, measles was declared eliminated in the US in the year 2000. Since that time, we have seen periodic outbreaks from importations through international travel. Most notable in the year 2019, when the US experienced the most cases and outbreaks reported in a single year since 1992, 22 outbreaks and over 1,200 cases of measles. Clicker again. Woohoo, here we go. So in New York City, there was an outbreak, and this was responsible for most of those cases. On October 1 of 2018, a US resident who'd recently traveled to Israel developed a measles rash after returning to New York. The disease then spread to other people in their close-knit, under-vaccinated community. Over the course of a year, additional travelers brought measles back to the community and infected others. More than 600 cases occurred as part of this outbreak. This year, Texas surpassed that number, with over 700 measles cases in one single outbreak, impacting primarily West Texas. Once again, most of those affected were unvaccinated children. Any measles outbreak that continues for one full year could lead to the US losing its measles elimination status. This moment calls us to think critically about these milestones and how these have contributed to the dramatic improvement in life expectancy the US experienced during the 20th century and the beginning of the 21st century, an increase of over 30 years. We can never take for granted the successes of the past and expect these wins are everlasting. We must be active participants of public health. This brings me to one additional mentioned public health achievement: the emergence of public health preparedness and response. This morning, I'd like to share with you my very own public health milestones, all from the point of view of a career epidemiologist with over 35 years of experience, practicing almost exclusively in Texas. My career has allowed me the honor of having a leadership role during coordinated responses to most public health emergencies this nation has seen in the last 4 decades. As epidemiologists, we monitor diseases, learn about their characteristics, their spread quietly and consistently every day in every corner of this very big state. But we don't do this work alone. We team up with many other public health partners. We depend on the collaboration of healthcare providers and their patients, the assistance of public health preparedness staff, such as planners, the tireless work of many nurses and other staff involved in the rapid deployment of mitigation strategies, the research and knowledge brought forth by colleagues in academia. There is one more partner that enables this work. I believe that at the core of successful public health surveillance, epidemiology, and response is a strong partnership and constant collaboration between epidemiologists and their colleagues in the laboratory. In order to understand clearly what we are working with, epidemiologists need laboratorians to help them identify precisely what is making people sick. They each bring a unique and important perspective to this work, and together with other partners, we are ready to face the next public health emergency. Collaboration matters. As many of you have heard, it takes a village. In my many years of experience, I have gained a very real world view of what an infectious disease emergency response looks like on the ground. I've learned that public health is a global issue. During this time, I have seen the devastation of AIDS, the first US cyclospora outbreak in the spring of 1996, which was associated with raspberries. There was a conference in a hotel not too far from here. Have responded to the emergence of SARS, the arrival to Texas of West Nile virus in 2002. In 2003, a monkey with suspected Mpox, which resulted in herpes simplex. Instead, he got it from his human owner, actually. In 2006, a human case of rabies, an outbreak of listeriosis linked to queso fresco, and the many other outbreaks that followed: MERS-CoV, Ebola, Zika, chikungunya, and pandemics. The 2009 influenza A H1N1 and COVID-19. And how to forget the response to Hurricane Katrina evacuees at Reliance Center, where we held a 24-hour on-site epidemiology response for over 2 weeks. And of course, most recently, responses to avian influenza A H5N1 and the West Texas measles outbreak. I have been involved in numerous responses from small and large-scale infectious disease emergencies and outbreaks. And during all this, I have learned that we don't do it alone. Collaboration matters. It is true that all emergency events, including infectious disease emergencies, are local, impacting the communities where we live, learn, work, worship, and play. Whether the event is relatively common as a foodborne illness outbreak or the flu, or very, very rare, like Marburg or hantavirus, an effective response that prevents illness and saves lives demands immediate attention. Local health departments, local healthcare providers, local emergency responders, and local government all work together to make this an everyday reality and are in the best position to exact immediate action for small and large-scale events. But they are supported daily by state epidemiologists, laboratorians, the entire governmental machinery brought forth by the state, and sometimes by the entire federal government. Collaboration matters. This machinery provides guidance, resources, uniformity to the entire enterprise. This is how we are at our best when we work together. Today, teams of epidemiologists across the state are on call 24/7, diligently monitoring disease patterns and looking for irregularities. In fact, the only way to recognize the unusual is to understand the normal. On a daily basis, we work with healthcare providers to conduct disease surveillance activities. Through our Health Alert Network, we communicate disease patterns and specific actions that are critical for disease investigation and disease control. In the years I've been in public health, I have seen 4 major pivot moments in the practice of public health epidemiology. I refer to a pivot moment as an event or a succession of events that resulted in change in a change in the practice that has been enduring, which has changed the way we conduct business. You see, when I first started in this field, we collected data. We were a little bit of data hoarders, I would say. This data was used to inform mitigation strategies, to write reports for our records and our funders. But by and large, the uses of data were internal and limited. Our responses were local and mainly informed by the activities on the ground. The actions we took rarely made it to the news. And if they did, it was informational and localized. we'll move quickly to the next task. Then 9/11 happened. And very quickly after that, the anthrax attacks to our country. We epidemiologists will forever refer to the latter as the investigation of powder incidents. The reason for this is that any and all epidemiologists at the time were overwhelmed with reports of powder incidents. Individuals who were allegedly exposed to powders from letters to candy wrappers and what could best be described as dirt in people's homes. Yes, we all receive those calls, including and most notably after hours. And yes, we would have to determine if these powders should be tested for anthrax spores. Well, following these events, public health epidemiologists became first responders, and we have been ever since. These events informed the need to expand public health surveillance, epidemiology, and response activities. Shortly after that, the Public Health Preparedness or FEP Cooperative Agreement was created to develop emergency-ready public health departments all over the nation. Pivot number 2, the diagnosis of Ebola in a patient in the US in 2014. By this time, the 24 hours news cycle, which could be argued began in the early 2000s, was very much a thing. Many of us remember the then governor of New Jersey and his efforts to quarantine a nurse returning from treating Ebola patient in West Africa. We saw her in that tent. Some of us have saw her in that tent. You know what I'm talking about? We followed her efforts to leave her home for a bike ride. This changed public health epidemiology into being publicly debated. By this, I mean mitigation strategies and public health recommendations that had been a daily activity of epidemiologists and public health officials became an endeavor of the public. This continues and has become even more noticeable since 2020, which brings me to pivot number 3, the COVID-19 pandemic. The most notable change for this era, I would say, is the use of data, big data, and the expectation for the release of daily accurate case counts, the visualization of real-time data. Before COVID-19, we dealt with hundreds, maybe thousands of cases. COVID-19 changed this by increasing the order of magnitude 1 power of 10. We now deal with tens of millions of records when we are cleaning, analyzing data, and creating these visualizations. And the expectation is that this information must be ready immediately. We have come a long way, but we are still, there's still a lot of work to be done. And collaboration matters. My long-term friend and colleague, Dr. Kelly Johnson, used to say about people who really did not understand how data works. You see, they think there is a key in the keyboard that you touch, and the result of complex data analysis will show up without much effort. They just appeared accurately and immediately with the touch of the F10 key, she would call it. I think some of you have that same going on. Anyway, I will say that this conversation, this was kind of our internal joke, which we refer to when we receive impossible data requests with little time, the F10 key. Well, these conversations took place a good 10 to 15 years ago. Back then, the processes were arduous and time-consuming, and the idea of complex dashboards and data visualizations we now have at our fingertips was not available to us in public health. I will say that the visualizations we are able to do today are still not quite like punching the F10 key, but we are closer to the F10 key concept with the automation of some processes. But collaboration matters. We need our partners in public health informatics who make sure we have access to data and data systems. Collaboration matters. In recent years, I have noticed what I will refer to as pivot number 4, the widespread use of social media for health communication. In my experience, I would say that this interaction with social media started in a meaningful way in public health around 2016, maybe. I worked then at a large urban local health department in Texas, not too far from here. And I recall around that time the first event in which we will quickly send public health messaging over social media and have staff available to respond real time to social posts. Even though it's been almost 10 years since that event, based solely in my observation, it is in the last few years after the COVID-19 pandemic, in fact, that I have seen the widespread use of social media to disseminate important public health messaging and to combat misinformation. According to an article published in the Journal of Medical Internet Research, as of the beginning of 2023, there were almost 5 billion social media users worldwide. This has been a game changer. Throughout this medium, we have access to individuals who are hard to reach through conventional health communication strategies and platforms. At the same time, we often find ourselves having to respond very quickly to inquiries about complex matters, while in the past, we would be allowed longer time to craft a well-thought-out response. This means public health has to be ready at all times, with crafted messages to address routine topics and ready to respond quickly to emerging issues and to correct misinformation. In an editorial published by the American Journal of Public Health in October 2020, the author states that there is consensus among national health agencies, public health researchers, and practitioners that misinformation on social media presents, and I quote, a critical challenge for public health. With this evolving landscape, developing professional relationships, creating partnerships, and collaborating across the Texas public health community is more important than ever to improve the health and well-being of Texans. In these coming years, we will continue to face public health emergencies due to the changing habitat, which allows vectors to thrive in areas and live in conditions they were not able before. Similarly, we will continue seeing and responding to severe hurricane and other weather events. To this, we should add the continued threat of vaccine preventable diseases, as vaccine hesitancy and overall lack of confidence in vaccine safety continues to rise in our communities. We have long known that any and all diseases are one airplane ride away. With the continued increase of globalization and travel, and we add to these migratory wild birds, potentially transporting illness over long distances through their flight paths. These are all opportunities for growth. We are to rise to the occasion and continue learning and applying the tools of the trade, which we have developed and exercised over years and decades of experience. From this epidemiologist's point of view, you take away the name of the disease, and to control the outbreak, the response is the same. Early detection of cases, investigation, and implementation of mitigation strategies. And we are all an essential part of this extraordinary, invisible public health infrastructure that must always be in place to ensure a timely and effective response for all emergencies and to keep Texans safe every day. Thank you.
Thank you so much, Dr. Martinez, for sharing those important milestones or pivot points, and for reminding us how far we have come in strengthening infectious disease preparedness. Your perspective really helps set the stage for the work ahead and inspires us all to continue building on that progress. I think, well, I was going to say I had a little note that we might have some people looking for seats, but I'm not seeing people standing in the back. So I think they might have found some seats, but we do have some additional chairs up front. You can make your way forward if you need to. And next, it is my honor to introduce our next keynote speaker, Dr. Varun Shetty. Since 2022, Dr. Shetty has served as Chief State Epidemiologist for the Texas Department of State Health Services. In this role, he oversees statewide disease surveillance, providing leadership in outbreak preparedness and response, represents Texas in national forums, and supports the DSHS commissioner as part of the executive team. He also leads the Chief State Epidemiology Division as deputy commissioner. Dr. Shetty's academic journey reflects both scientific depth and a commitment to service. He graduated from Union College in New York with a Bachelor of Science in Biology and Political Science, and is also an alumnus of the AmeriCorps National Service Program. He went on to earn an MBA in Healthcare Management from Union Graduate College, now Clarkson University, and a Master of Science in Biomedical Sciences from Tufts University School of Medicine in Boston. He then received his Doctor of Medicine degree from Tulane University School of Medicine in New Orleans. I'm kind of taking you all over. Following that, he completed his residency training in both internal medicine and pediatrics at Rush University Medical Center in Chicago, where he was also selected to serve as chief resident in pediatrics. His professional career has been marked by critical service in times of need. In 2019, Dr. Shetty joined the Centers for Disease Control and Prevention as an Epidemic Intelligence Services Officer, where he was assigned to support the Texas Department of State Health Services. In 2021 and 2022, he continued in Texas as the CDC Career Epidemiology Field Officer, providing leadership for medical epidemiology and emergency preparedness activities across the state. We're certainly glad that your journeys have brought you to Texas. Please join me in welcoming Dr. Varun Shetty.
Thank you so much, Leah, for the introduction. Can everybody hear me okay? If I'm standing up, I'm a little bit soft-spoken. Okay, and my picture looks like a ghost, or this is like in memoriam or something like that. So thank you so much, Leah. Thank you, Dr. Rios, and the TEPHI team for inviting me to speak today. It really is an honor, and it's humbling to be in a room, the room that we're in right here, and also the virtual space. I know there's many people who are here that are just so engaged and important to our public health community. So thank you so much for the opportunity. And I would like to just kind of say thank you again to Dr. Martinez for those really lovely remarks earlier today, just before this. And I think I love that presentation because I think it so effectively frames the challenges that we face today. And I think looking back and really paying attention to those lessons helps us be better prepared for what's coming next. And so today, my talk is going to be focused on some more current issues that we're dealing with today. We'll be talking about the big outbreak that we just have moved past, the measles outbreak of 2025. Then we'll be talking about activities that we're really just launching into right now, the 25-26 respiratory season, and then pivoting to something that's coming down the road that we're preparing for, and that's the New World screwworm activity. As a disclaimer, this is based on information that is the latest, the most up-to-date information that we have available, but is of course subject to change. So I'm going to start by talking about measles, and what I'll try to do throughout my talk is to pull out some of the lessons that Dr. Martinez highlighted in her remarks. And I think that with measles, I would actually start by just thinking about the concept of looking to history. This is a topic that probably everyone in the room had at the top of their mind, especially in recent years. But most of the country was not thinking about measles, and that's largely due to the success of our vaccination programs over the last several decades. When measles started to emerge in the state, we had to do a lot of education and reminding people about this disease and why it was so important to take this seriously. And so we did a lot of teaching. We reminded people about how contagious measles is. It's the most contagious viral infection that we know of. If one person has it, up to 9 out of 10 people will become infected if they're not protected. And that the best protection is through vaccination with the measles, mumps, rubella, MMR vaccine. We also had to remind people of the consequences of getting this disease that can cause serious health complications, especially in children younger than 5, pregnant women, and people who are immune compromised. We had to remind ourselves about the details of this virus, the incubation period, the prodrome, the rash. I remember speaking to many providers, myself included, there have been generations of medical providers who have never seen this disease. And so, it was always a sort of a conceptual topic in our textbooks, but to really think about how this presents, how it presents in different people, in people with different skin tones. It was really important to make sure that people were up to speed on the details of this disease. We spent time talking about the clinical presentation, how this rash first forms along the forehead, spreads down the body, reminding people about the Koplik spots, the whitish spots on the roof of the mouth and on the buccal mucosa, and the various stages of clinical presentations. You can see a rash on the cheek of that child on the left-hand side, a disseminated rash across the body of that child in the middle, and then the resolution, the sloughing of skin as that child recovers on the right-hand side. And then, of course, reminding folks about the serious complications that can happen. So secondary bacterial infections, severe illness requiring hospitalization, including diarrhea leading to severe dehydration. And then the more rare and severe outcomes, 1 out of every 1,000 measles cases will develop an acute encephalitis, which often results in permanent brain damage. And then 1 to 3 out of every 1,000 children who become infected with measles will die from respiratory and neurologic complications. And then we think about some of the scariest outcomes, subacute sclerosing panencephalitis, or SSPE, which is a rare but fatal degenerative disease of the central nervous system. And it leads to a rapid deterioration and is universally fatal. When I was training in internal medicine and pediatrics, this all seemed so distant. It seems so theoretical, but it's happening right now. In fact, just this month, LA County reported a case of a death due to SSPE in a school-age child who was infected with measles as a very young child, and as we know can happen, several years passed, and then this devastating outcome occurred, and a child has died because of it. So this is real, and it's happening right now. If we think about history, and I know you saw a version of this slide in Dr. Martinez's presentation, it's important to paint this picture and make people realize that we did have so much success in our immunization programs. After the first measles vaccines were introduced in the 60s, you saw that rapid decline in cases. where before that we were seeing hundreds of thousands of cases, and you can imagine the disease burden that was associated with that. And then with the advent of the second dose, the amazing achievement that we were able to have with elimination in 2000. We had to remind people about how effective and safe this vaccine was in a really complicated environment. I'll try to pull out one of the points that Dr. Martinez was mentioning about how public health became more of a debate and more kind of discussed in the public square. There are some things that are, just clear facts, and we had to really make sure that people understood what the facts were. This was a vaccine that was that is tried and true, that we've had access to for decades and decades, and that has stood up to the test of time and has been incredibly effective. And then you can see how that trend has changed in recent years. This is a snapshot from CDC of US measles case trends, and you can see how those numbers have been climbing slowly but steadily over the past several decades. And then most recently, leading to the year 2025, where we've seen historic numbers. Underlying all of this is concerning trends in vaccine coverage. You can see here a comparison of the year 2009 and 2010 to 23-24. This is MMR vaccine coverage for kindergartners by school year. In Texas, we were at that goal level of 95% or above MMR coverage back in 2009, 2010. And that has slipped over time, but you can see that's not unique to Texas. We are seeing that really concerning trend across the country and really across the world. And I mentioned the world. This is a snapshot really just of the Americas, but you can see just in the year 2025, the immense global burden that we have seen for measles throughout the world, but including throughout the Americas. There have been, I'm looking at the numbers here, over 11,000 cases of measles in the Americas in 2025. That is a 33-fold increase in measles compared to the same time period in 2024. And that includes many deaths reported in a number of countries in this time period. Now, what all of these trends have set us up for is the possibility of large outbreaks, particularly in large, close-knit, under-vaccinated communities. There is just the potential for these large outbreaks now. And that's exactly what happened in our state this year. So we recently were able to declare this outbreak over. And so this is at a glance between January and August. We had a total of 762 confirmed cases. That included 99 hospitalizations, 12 ICU admissions, and tragically 2 deaths among school-aged children who were unvaccinated and who had no known underlying medical conditions. I want to pause here on this slide and just recognize that behind those 762 cases are probably 1 million stories of just tireless work, including by many people in this room. Collaboration, as Dr. Martinez alluded to, self-sacrifice, working at all hours to make sure that we were doing what we could to keep people safe and informed and to control this outbreak. It was just backbreaking work. And I know that there are many people in this room who were really just incredibly engaged in that at the local level, at the regional level, at the state level. My team, who's here and many who are not, it was an honor to see that work on the ground. And I just wanted to say from the bottom of my heart, thank you for all the effort that went into that. Here's our epi curve, and you can see just the incredible rate at which this outbreak took off, particularly in the South Plains and the west area of West Texas, and we'll look a little bit more at the geography later on. And here we are. So you can see how this outbreak was really largely concentrated in that area of West Texas where there was a very large, close-knit, persistently under-vaccinated community, and just many opportunities for spread within families, within households, within communities, and community settings. We had spread beyond that area, but it was much more limited. I think that we often talked about the concept of a fire that was burning in that part of West Texas, and you could see embers pop out to other areas, but you hoped that they were popping into places that had much more protection and much more resiliency for those introductions. And thankfully that largely did happen. Here you can see some sort of big picture characteristics of the outbreak, the breakdown by sex. You can see, and I really want to emphasize the disparate impact that this outbreak has had on our pediatric populations, where you can see the highest impacted group was school-age children, age 5 to 17. But you can also see, over 200 cases, 225 cases among very young children, 0 to 4 years of age. We talked about the 99 hospitalizations. Roughly 70% of those hospitalizations were among children less than 18. And then I want to spend some time talking about the outbreak cases by vaccination status. I think that this was a really important demonstration of the effectiveness of this vaccine in a real world large outbreak setting. This vaccine held up, and you can see that the vast majority of our cases were among people who were unvaccinated or who had unknown vaccination status, and far fewer among those who were vaccinated with either 1 or 2 doses. And this is just a somber reminder of the 2 deaths that we did experience as part of this outbreak. We've also had cases that were not associated with the outbreak. As of September 9th, there were 41 non-outbreak measles cases reported in Texas. Many of those were associated with international travel, and some it was just difficult to understand. So there were sometimes exposures to other domestic cases in amusement parks, restaurants, schools, conferences, other gatherings, and then some where it just really hard to tease out in a growing, in a more and more complex environment with measles infections as spread has occurred around the country. It can be really difficult to tease out exactly where these cases are coming from sometimes. So our next section here is about our communications around measles, and I wanted to pull out another lesson from Dr. Martinez, which is, we live in an environment now where, as she said, there's a need for information, and for that information to be accurate and available right away and all the time. And we're constantly kind of under that pressure that requires us working together, that requires collaboration in a large state like this, in a large decentralized state. That means that we have to be working together so we're on the same page about what information we're putting out. Because if our news release says something different from your news release, that causes a conflict, and we're fighting a different battle. And so, I know that, on the ground, epi to epi, were constant conversations. Sometimes those were challenging conversations just to be on the same page in a really dynamic and complex environment. But we took great pains to meet the need at the time for getting information out as quickly as we could. We mobilized very quickly to stand up some dedicated resources on our website to put out our measles outbreak vaccination recommendations. We had a news alert page where we were updating twice a week the latest numbers so that folks can be up to date, be informed, understand the trajectory where things were headed. We had an outbreak specific page that included a communications toolkit so that our partners around the state had accurate information and tools that they could use to communicate in a digital environment where people are getting information online. We needed to be in those spaces as well to provide trusted information. And then we also launched a public awareness campaign to try to just raise the profile of what was going on, make sure that people knew where to get the resources that they needed to stay safe. Here's an example of taking really complex information and trying to boil it down into a bite-sized tool. In the type of media environment that we're talking about, it's so important to speak responsibly about scientific information and in a way that people will actually understand and be able to use that information in their lives. So this is just a one pager that was designed by our communications team that tried to distill down what was actually a very complex discussion about vaccine recommendations in outbreak areas, where we knew that there was a lot of demand around the state to be proactive, to do something to protect yourself and your loved ones as this outbreak was spreading. And so you need to know quickly, what's my situation, what is recommended for me, and why. And so this is an example of that. And then I mentioned our news and alerts page, updating information as quickly as we could. To update a website twice a week, every week for months and months requires just a tremendous amount of effort for our staff and our partners around the state. We also had on our website basic information about symptoms, when to seek emergency care. This became a really important topic as we were starting to see that some people affected by this outbreak were hesitant to present to care, or they were maybe seeking alternative forms of care, and they're really showing up to the emergency room much later than they should, and that leading to worse outcomes. And so we really tried to get the message out about what are the signs and symptoms that you need to be on the lookout for yourself, for your loved ones, for your kids, that prompt you to go to the ER quickly. And then we developed, many FAQ resources about measles and then about measles vaccine. And then these are just more examples of our communications toolkit. So what can we say in a way that expresses the severity of the situation, gets people the information they need to be able to take clear steps to keep themselves and their families safe. And for people who spent time on these websites, you know that there was just really a mountain of information here. There were digital tools, there were messages you can pull into social media. We had a number of videos from our commissioner, Dr. Shuford, talking about ways that you could protect yourself and your family. When should I seek emergency care for me or my loved ones? Why is it important to get vaccinated, especially in school settings? So just trying many different strategies for messaging that could hopefully break through. And then here's our public awareness campaign. This outbreak took off in a really initially in a really rural part of the state, where you needed to be on the ground and you needed to be going to the Walmarts and getting physical posters up so people can see. We had a mobile van that was driving around town, getting the message out. And then as the spread occurred, we started to see cases in larger cities and communities. And so trying to find messaging strategies that work across a lot of different areas was a challenge, but one that we really spent a lot of time and effort on. And so that will end my discussions about the measles outbreak. But I think it just pulled together so many of those lessons that we learned. This was a historic outbreak in a modern time with all the challenges that come with that. So pivoting now to sort of what we're looking at just in front of us right now, and that's the coming respiratory season. This is always one of the bread and butter challenges that we think about in public health. And in recent years, this has been a more complex topic. So emerging from the COVID-19 pandemic, all of a sudden our baseline is higher than it was in the past. We now have flu and RSV as always, but another major respiratory disease that leads to emergency department visits and hospitalizations and burden on our healthcare systems. And that's just at baseline going forward. And so when we talk about preparedness, I think it becomes even more important to really understand at a near real-time level what is emerging, what is circulating, and how is that impacting our healthcare systems. And so I wanted to pull out another lesson from Dr. Martinez, which is how do we use technology and data and data visualizations to inform those discussions and those preparedness activities. And one major approach that we've taken at the health department is the development of this Texas Respiratory Illness interactive dashboard. So we launched this a couple of years ago. This lives on our website at Texas Health Data, where we collate a lot of our really important data sets and visualizations. And this is what it looks like. I'm going to spend some time walking you through this. If you're not already familiar with it, I hope you will get familiar with it. This was a great collaborative effort across a number of different areas in our department to pull data from different parts of the state, of our state data sets, and to present them in a way that hopefully is engaging, interactive, and easy to use and inform decision making. This pulls together emergency department data from our syndromic surveillance systems, hospitalization data from the National Health Safety Network, as well as death data from our death records surveillance system, and visualizes the trends in COVID-19, influenza, and RSV over time. So this is our landing page and our statewide snapshot. You can see sort of at a glance, what appears to be like an epi curve, and that's looking at the percentage of ED visits associated with those three viruses over time. So you can kind of see where we're at overall in the season. And then the three tiles here are showing at a glance trends for ED visits, hospitalizations, and deaths. And then you can click into any one of those and get more information. So here we can see the weekly emergency department visits for each of these three viruses. You can see RSV in red, influenza in blue, and COVID-19 in green. And then you can visualize at a glance the increasing burden that we have been experiencing leading into September for COVID-19. You can toggle this you can select specific periods of time. You can select specific regions of the state. And then you can also view by age group as well. And so here we can see that breakout of weekly ED visits by age group. This is specifically, this is combined across the three viruses. And so you can see at a finer granularity how these ED visits are actually occurring much more among the youngest children in our state. And so that's a really important piece of information as we are preparing for the coming season, as healthcare systems are trying to understand what's going to come through their door. And here you can see our hospitalization data. So these are hospitalization rates for COVID-19, influenza, and RSV. And you can see again, that increasing trend for COVID-19 in recent weeks and months. And then trends in viral respiratory deaths in Texas. And I think the big takeaway here, this is looking at the overall proportion. So the proportion of total deaths that are attributable to one of those three viruses. I think overall, it's a relatively small percentage, less than 1%, but you can see that among that amount, the burden among COVID-19 is significant. And then we can also break that out by age, and you can see in at least in broad categories who's being impacted the most. So that's talking about what we are currently dealing with. And next, I'm pivoting to a challenge that we are expecting to come down the road and that we're preparing for. And important to note, I want to give a shout out to our state public health veterinarian, Dr. Susan Rollo, who's here and is a critical leader on this topic. And you'll have an opportunity to hear more from her on the panel. But I'll do my best to talk about this topic of New World screwworm. So New World screwworm is not actually a worm. It's a fly. So these are larvae of the fly Cochleomya hominivirax. The female flies lay eggs in wounds or on mucous membranes of warm-blooded animals. And once they hatch, this parasitic larva burrows into the animal to feed on that living tissue. It's a really difficult concept to hear, and then you're kind of haunted by it going forward. But it's a really devastating infestation, and it leads to severe damage of that tissue in a process called myiasis. And you can see in the images below the fly that lays the eggs on the left-hand side, and then the actual maggots in the middle with a screw-like appearance, which is where they get their name. And then on the right-hand side, the egg burden and the larvae that are present in the wound in this animal. And so you can imagine, the devastation that this causes an individual animal. It can lead to severe secondary infections, severe illness, and if it's untreated, death in that animal. New World screwworm is currently endemic in South America, Cuba, Haiti, and the Dominican Republic. We had eradicated this from the United States back in the 1960s using what's called a sterile fly technique. So you introduce sterile male flies, and then when new flies or when mating occurs, there's not an opportunity to produce more flies. That was a highly effective strategy in the 60s, and we were able to drive New World screwworm all the way down to Panama. To further prevent the spread, the Commission for the Eradication and Prevention of New World Screwworm, or COPEG, was established. And that has been a very effective barrier for a long time, but until in recent years, since 2023, we saw that protection, but then we started to see that that protection break. You can see on this visualization how cases have started to creep back up through Central America and through Mexico. And this is a major concern for us, and one that we are really paying close attention to and preparing for. There are a number of ideas as to why this breach happened. Part of it may have to do with changing uses of the land, deforestation, and to allow for more grazing of animals, and the movement of animals into new areas of land. There has been some effort also to update the sterile flies that are being produced in case a more effective fly could limit the spread. So we've been watching very closely as this has advanced up through Mexico. And very recently, on September 22nd, there was a report from Mexico about an infestation in an animal near Nuevo León that is just 70 miles from our southern border. And so this is something that we are monitoring very carefully. Since 2022, there have been over nearly 6,000 animal cases in Mexico, with 743 active, and that number is going to change dynamically. We are thinking about the resources that we have available to control this spread, and at the moment, they're somewhat limited. So COPEG, the institute I mentioned in Panama, is the only sterile fly production facility, and it produces up to 100 million flies per week. And so there's a lot of thinking that's going into how can we expand the capacity for that facility and potentially create more sterile flies. Because the current demand at the rate that this is spreading is exceeding the capacity for that facility. This is a topic that is being taken very seriously at all levels of government. On August 26th of this year, HHS and CDC reported an identified human-related case. This was a travel-associated case of New World screwworm in a Maryland resident. This is unique in that this was a person who had traveled to a part of this outbreak area and not an endemic part of the world. There was action that was triggered immediately following the identification, including surveillance within a 20-mile radius of the affected area. And to date, there has been no additional evidence of New World screwworm in that area. Talking through the clinical management of human cases, there is no medication to treat New World screwworm infestation in humans. There are anecdotal reports of using ivermectin as an off-label treatment. However, there have been no controlled double-blinded studies measuring the impact of ivermectin use on New World screwworm myiasis. So the critical thing that our providers need to know about is that myiasis in humans is treated by removing the larva from the wound. And it's incredibly important to remove all the larvae from the wound to prevent the possibility of larvae falling out, pupating, and furthering the life cycle. And so when a patient presents to the provider, they will remove all those larvae. They will put them in an alcohol solution to both kill the larvae, but then also preserve them for identification. This is a really critical step in the chain of public health actions. CDC has been releasing information on this topic and recently released a recommendations for healthcare providers document in the beginning of this month. You can see the picture here gives you sort of a sense of the size and scale of the screwworm larva. In terms of treatments for animals, there are currently no FDA-approved drugs for New World screwworm in the United States. HHS took action to allow FDA emergency use authorization for certain animal drugs for New World screwworm myiasis. So, the hope is that that will generate kind of rapid development and evaluation and approval for the use of medications for animals. And that is information that we're monitoring very closely as well. This is also a top priority at the state level. Governor Abbott appointed the Texas New World Screwworm response team that includes leadership from agencies across the state. And I think this is another lesson from Dr. Martinez's presentation that we can pull here, is just the critical need for collaboration across different areas. I think this highlights, even beyond what we typically do in a lot of public health activities. This requires a One Health approach. Dr. Rollo has been, a leader in advancing the One Health mission in the state of bringing together human health and animal health, because we all will need to work together to take on a challenge as daunting as this one. So we have the Animal Health Commission involved, Texas Parks and Wildlife Department, Department of Agriculture, Texas AgriLife, all part of this response team, including bringing a lot of other critical partners to the table, industry groups that represent main livestock species, as well as property rights and ranchers groups as well. Dr. Rollo is our public health representative. I sit on this team as well. We have had really productive discussions in preparing for our response to these activities. This is just so you can be aware of the information that is coming out on this, and so you can start to learn from the CDC COCA calls. They have a webinar through Project Echo to get information out to providers. So this can be something that they're on the lookout for, and to do that critical identification and the first steps of the public health chain of events. And some additional resources up here. And I think that takes me to the end of my presentation, but I wanted to really close by saying that, I wanted to recognize that it's a difficult time in public health right now. And I would understand if, some of you are feeling discouraged at that time. And I think that for myself and what I tell, my teams is, I think that at times like this, it's really important to remember why you're doing what you do. If you are like me, and I suspect that many of you are, you came to public health to serve. You came to public health to make an impact. You came to be where you could be most useful to your community. And that has never been more important than it is today. Hopefully you've heard from Dr. Martinez and myself that, the challenges that we face they continue to come. They continue to become more and more complex. The work you do matters. It matters a great deal. It matters now probably more than ever. And I'm biased, but I think that it matters more here than almost anywhere else in the world. Texas is an incredible place to practice public health. When you think about just the sheer diversity of our population, the size and scope of the communities that we have to protect and take care of and think of here. You think about the diversity of our landmass and our ecology, the environmental diversity in the state. We've got coastal climates, we've got desert climates, we've got everything in between. We've got big cities like Houston that invite people from all over the world, and international ports of entry. And then we've got teeny tiny counties like Loving County, population 64, and it's just it's a state that requires the best of public health, and it requires all of us coming to the table and working together to meet these challenges as they're coming. And I think it's really special for me to be in rooms like this and look around and say, yeah, here you are. You're all here showing up every day to take on the challenge. And I just so appreciate you doing that and doing that every day. So again, I'm really grateful to have the opportunity to be with you today. And really looking forward to the chance to engage with a lot of you as the day goes on. And so just thank you for the work you do, and please keep doing it.
Thank you so much, Dr. Shetty, for that comprehensive look at infectious disease in Texas this year, what we have on the horizon, but also for that encouragement to keep doing the work we're doing and the reminder to return to why we're doing this work. It definitely it provides that motivation, I think, when some days the news cycle might just shock us. So thank you. Another round of applause, please, for Dr. Shetty. And we'll now take a 15-minute break. Please take the time to stretch, refill your coffee, use the facilities. Reminder, they are out the door to my left. So when you walk out straight to your left, and please be back right at 10:15, we'll say, with your raffle tickets. Thank you.